roughly around six folds increase in the cases of neuroendocrine tumor. In 2019, we have an update in terms of the pathology. We have a new WHO classification and grading criteria. And now we have what's called the neuroendocrine tumor and the neuroendocrine carcinoma. The neuroendocrine tumor is the well-differentiated net, and we divide G1 from 2 to 3 based on the grade, mitotic rate, and the Ki-67. For the neuroendocrine carcinoma, we either have the small or large type, and usually it's the poorly differentiated with a high Ki-67 mitotic rate and grading. Also, we have another entity, which is the mixed neuroendocrine, non-neuroendocrine neoplasm. So neuroendocrine tumors are a heterogeneous disease, and the extent of disease is important. The pace of growth is important. What's the primary site? What's the grading, the differentiation? Is it functioning or not functioning? And what's the somatostatin receptor status? Is it a high expression or low expression? And what's the metabolism? Moving to the intermediate grade. So for the small bowel NET and the pancreatic NET with G1, G2, STR positive with Ki-67 less than 10%, based on the recent ESMO guidelines from 2020, the first standard of care is the somatostatin analog. And the role of the SSA in the NET is actually for symptomatic and anti-proliferative therapy. So somatostatin analog there has been an improvement of flushing and diarrhea is achieved in 70 to 80% of patients by using a slow release formulations. And that's why octreotide standard first-line therapy in functioning neuroendocrine tumor. It has also a proliferative, anti-proliferative effect. There has been retrospective studies and have shown an overall stabilization of tumor growth in 50% of patients and partial response in up to 10% of patients. We use octreotide from the PROMET trial, which was in the midgut neuroendocrine tumor, and it was also in the functioning and non-functioning tumors. And the primary endpoint was the time to tumor progression, and it was 14.3 versus 6. And the hazard ratio was 0.34. 60% of the patients were asymptomatic, and there was a significant benefit in patients with less than 10% liver tumor load with a significant hazard ratio of 0.17. We use lanreotide based on the CLARINET trial, which was in the GEP-NET. And in this study, it was only for the non-functioning tumors. And the PFS was not reached in the lanreotide group versus 18 in the placebo group with a hazard ratio of 0.47. In the subgroup analysis, there was benefit in the midgut pancreatic and the rest of the subgroup. When we look at the safety profile, lanreotide has a similar safety profile consistent with the other somatostatin studies, and diarrhea is the most frequent adverse event. CLARINET 40 was presented in the last ESMO, and it's a phase 2 study. It was to assess the efficacy and safety of increasing lanreotide dosing from every 28 days to 14 days. And it was in progressive PAN-NET or midgut NET. And the inclusion criteria was for SSTR positive, grade 1 or 2, Ki-67 less than 20%, functioning or non-functioning tumors. PFS in the midgut was 8.3, and in the PAN-NET was 5.6. Stable disease was similar in both groups, and the disease control rate was 43 versus 58. Important to highlight that post-hoc efficacy endpoint showed a significant benefit in tumors with Ki-67 less than 10%, especially in the PAN-NET. And a majority of the toxicity was a grade 1. Most common side effects was GI disorders. The conclusion from this trial provided an encouraging PFS and duration response and in patients with progressive PAN-NET, in particular patient with Ki-67 less than 10% and mid-gut NET. No new safety concern, and this study showed that escalating the lanreotide dosing frequency may prove to be a consideration before switching to an alternative, more toxic treatment. Moving to the PRRT, so we use PRRT in the small intestine neuroendocrine tumor as a second line after progression. There is also rule to use it in the pancreatic NET. For SSTR negative and NET grade 3, there is no, we can't use actually this. And NETTER-1 trial, which was evaluating the efficacy and safety of lutetium dotatate plus the somatostatin analog compared to an octreotide at higher dose, 60 milligram. And it was an inoperable somatostatin receptor positive mid-gut tumor, progressive under octreotide LAR 30. And they received 4 doses, and then the initial presentation in ASCO 2016 showed that the PFS was very significant with hazard ratio of 0.21, and there was a 79% reduction in the risk of disease progression and death. And the estimated median PFS at that time was around 40 months. The overall response rate was 18 versus 3%. And in the last ASCO, there was more update about the overall survival, and the median OS was 48 versus 36. Hazard ratio was 0.84. The conclusion from the NETTER-1 update is, with a median follow-up of more than 6.3, the pre-specified final analysis of OS in the ITT population did not reach a statistically significance with a hazard ratio of 0.84, potentially impacted by a high rate of crossover. The other thing is there is no new safety signals emerged, and in overall conclusion, lutetium dotatate led to a clinically and statistically significant improvement in PFS, hazard ratio 0.18, and a clinically meaningful improvement in median OS of 11.7 months. There was also another NETTER-R, which was also in ASCO 2021. It was an international retrospective registry using lutetium dotatate in the pancreatic neuroendocrine tumors. And it did show that it's well tolerated with a safety profile consistent with NETTER-1 trial. And the OS and PFS compared favorably with studies of progressive PNET treated with other systemic agents. And the results support previous findings and reinforce the role of lutetium dotatate in the treatment of patients with SSTR positive PNET. From the ENET's consensus guidelines, the inclusion criteria for using the lutetium dotatate is for inoperable metastatic well-differentiated grade 1-2 NET. For the well-differentiated grade 3 NET may be considered. There is recent data. We're waiting for further data from this study. Patient has to have sufficient tumor uptake on the somatostatin receptor study, sufficient bone marrow reserve, creatinine clearance of more than 50, good performance status, and expected survival of more than 3 months. Moving to molecular targeted agents. In pancreatic NET, we have Sutent and everolimus from Sun-111 and Radiant-3. PFS is quite similar in both trials, and response rate was less than 10 in both. For when we look at the dose intensity, dose interruption, and treatment discontinuation was similar. Toxicity profile, although, is different. When we look at also if a patient received prior somatostatin analog or prior chemotherapy in both Sutent and everolimus study, there is still benefit, and it was unaffected by using a prior therapy, although both groups did not receive prior targeted therapy. Radiant-4 was using everolimus in G1, G2 lung and GI NET, and the PFS was 14 versus 5.5 with hazard ratio of 0.39. When we look at the subgroup analysis, there was benefit lung and GI. Important to highlight that there was more benefit in the non-midgut with hazard ratio of 0.27. So how do we choose for our patients? So generally, we favor using targeted therapy if there is a low tumor burden, low tumor-related symptoms, low rate of progression, and we're not looking for conversion therapy to make it resectable. Then we would use either everolimus or Sutent based on the patient comorbidity. If the patient has hyperglycemia, chronic steroid use, major pancreatic resection, then everolimus is not favored. If the patient has poorly controlled hypertension or significant cardiovascular morbidity, then Sutent is not favored. Sequencing. So this is the ESMO recent guidelines, and as you can see here, sequencing. It's important to mention that sequencing therapy was not based on randomized clinical trials. So, and there is lots of ongoing clinical trials testing what's the best sequencing of these therapy. There is trials testing Sutent versus PRRT, everolimus versus chemotherapy, everolimus versus PRRT, and hopefully we'll get results soon to guide us on how to better sequence these therapy. There's an emerging angiogenesis inhibitors in NET. There's the sorafenib, which is approved now in China. Axitinib, there's recent data, and we're waiting for more data in the coming ESMO. There is some evidence on cabozantinib, lenvatinib, and bizartinib. For the sorafenib, there's the SAN-ET-EP and the SAN-ET-P. So it's both Chinese trial. In the SAN-EP, it was in the extrapancreatic NET. 84% were grade 2. Majority were 27% rectum, 12% lung. Median PFS was 9.2 versus 3.8, and the overall response rate was 10 versus 0. In the pancreatic group, PFS was 10.9 versus 3.7, and these two studies made sorafenib is an option for another option for GI, pancreatic, and lung NET. Systemic chemotherapy. So for the well-differentiated neuroendocrine tumor, usually we use chemotherapy in the PAN-NET with Ki-67 more than 10 in G2 or G3, and also when we look at the clinical trials, there's many historical studies. In the light pink is pancreatic, in the dark pink, which was carcinoid small bowel. As you can see, response rate is variable as well as the survival. But the key points or key messages from the early studies, activity of chemotherapy is higher in pancreatic NET than in the non-pancreatic NET. Response rate were not assessed by currently used robust methods, and adding ceftriaxone efficacy increased in combination with either 5-fluorouracil or doxorubicin with additional toxicity. This is a systematic review in a non-pancreatic well-differentiated neuroendocrine tumor, and it included 20 studies. Median PFS was 16.9, median OS 32 months, and the response rate 11.5. And from this response rate, the recent ESMO guidelines stated chemotherapy cannot be recommended in this setting. Pre-selection of patients with a higher Ki-67 between 15 and 20 and significant progression might be associated with benefit. And the conclusion from this systematic review, well-designed prospective studies are needed. CAPE is from a retrospective study, included 30 patients in metastatic, well or moderately differentiated PAN-NET and no prior chemotherapy. Median PFS was 18 months, median OS not reached. Grade 3 to 4 adverse events were in 12%, and the radiologic response was around 70% of patients. Is there a role of MGMT in neuroendocrine tumor? And this question is not answered yet, but this is a very elegantly designed French trial, and hopefully we'll get more information soon to know if there is any role for MGMT in neuroendocrine tumor. Moving to the poorly differentiated NEC. So NEC grade 3 histologically and clinically behave as similar to the small cell lung cancer, for which chemotherapy recommendation is cis or carbo plus ETOP, and upon progression based on the guidelines recommendation for FOXO or CAPTEM can be used. So this is a survey of practice in 11 countries, and as you can see, there's a 15 regimen used, and what's highlighted in the light pink is the commonly used, which is cis-ETOP, carbo-ETOP. Sure. Important to mention that there is no standard treatment in the second line. And for the immune checkpoint inhibitor, there is no strong data in the GI net yet. There is lots of ongoing trials, some promising data in the lung net with high tumor burden. So in summary, in the absence of definitive predictive marker, comparative randomized trials, the treatment should be based on the clinical and pathological features and the SSTR imaging. And it's very important to discuss every neuroendocrine tumor in the tumor board in an experienced center, including experts familiar with the disease. Thank you.